welcome. So, you're the Chief Nursing Officer at Springfield Hospital.
I am.
It's probably a big title with a lot of hats.
It certainly is. Yes, if someone were to ask, well, what do you do? Put out fires, prevent fires, fire prevention, firefighting. Yeah, depends on the day, but mostly operations, keeping us running.
Yeah. And how did you get there? Tell us your background a little bit. How long have you been?
Goodness. I've only been at Springfield a little under 2 years at this point. I started out as the associate under Lori Profato, and then moved up to this position, the chief position, in December. And so I'm loving it so far. It's been phenomenal. Mm-hmm. But from the area, grew up here, born and raised in the Brattleboro-Windham County area, and had got my start at Brattleboro Hospital, and then Grace Cottage Hospital, and in between that, I was a police officer here in Bellows Falls. And
oh, really?
Oh, really?
Yeah.
Oh my gosh, little known but interesting fact.
Yes,
we're going to have to explore that a little bit.
Oh, absolutely, yes, yeah.
Okay.
And the other part of my life has been EMS. So I worked with Jerry Lefevre when I was just a child, and then moved on to Rescue Inc. in Brattleboro and stayed
really
there
cool.
for quite some time.
It's so nice to have someone so local.
Yes.
It
Oh, thank
really
you.
is.
Yeah, I love it. So yeah,
And also
I love
so
this area.
well-rounded, because a lot of, EMT, you got to think fast on your feet. I mean, just a lot of skill sets that might not always come with people in the position you're in. I'm not speaking well today. Might not always come with that much of a package.
Yeah. I think it gives a nice perspective. Yeah, it's all of those positions have contributed in some way to having skill sets for this job now. So yeah, absolutely.
So do tell, when were you
Yeah,
there?
when were
I
you
know,
police
no,
officer?
you've
Now we're
totally thrown us.
fascinated.
We will get back to Springfield Hospital. We're totally fascinated.
I worked in a part-time capacity under Keith Clark, so it must have been 2003, and for about 7 years.
Wow,
So,
that's amazing.
One of his patrolmen, and worked with a really great group of people and learned a ton. And a lot of them were people skills, and so those are transferable. So it was a very good start. Yeah.
Oh, that's awesome. That's so funny. I know that would have won the trivia contest at little known but interesting facts about Rebecca. We would have never guessed. So what is it like day in the life? You said you're putting out fires. Like how many departments or what do you oversee?
I oversee a lot of patient-facing departments. And so anywhere that you would encounter a nurse in our hospital system. So the Windham Center, the inpatient unit, the emergency department, perioperative services, infusion clinic. Oh my gosh, I hope I'm not forgetting somebody. I'll hear about it. Oh my gosh, adult day. I did. Okay. See, look at me. And then also the pharmacy and cardiopulmonary. So some of those departments are inpatient as well as outpatient. And so there's you have an opportunity to meet any place where you have an opportunity to meet those nursing staff. That's who I am working with on a daily basis. So
approximately how many nurses are there at Springfield Hospital?
Oh my gosh, that's a trick question. I should know this.
We tried not to do
that. I know. That's a great question. Off the top of my head, I know that the hospiel itself employs around 400 people, and there's a good number that are support staff. Nurses and support staff. So we would love more. We are currently experiencing a phenomenon that most hospitals in America, let alone critical access hospitals in rural locations, we have a bit of a deficit for staffing. We're all kind of sharing the same pool, which is kind of tough. We do have agency staff, which we're very grateful. So travelers who've come in and helped us stay open and keep our doors open and our patients well cared for. They are a little more expensive. So we're really hoping to hire people who live in our community and want to see our hospital grow.
Well, I see a lot of I've just seen at least 2 or 3 recent graduation pictures of folks graduating from nursing school. So I can only hope that they were going to stay locally. So maybe you can speak to some of the benefits of being a local, like working locally.
I've had the opportunity in my career to work at other hospitals as well. Dartmouth was one of them. Incredible place, a wonderful place to grow and learn and all of that. And so what we are trying to do at Springfield is also foster that same level of opportunity to expose new staff, new nurses to different opportunities, and then to be able to support them through those transitions, floating, if you will, through other departments. Education and onboarding is really important to new nurses. And so it can be very scary to leave school and suddenly not have a preceptor or a group that you're with. And to be faced with those challenges and you kind of feel isolated and alone. So what we try to do is foster a really strong onboarding program. In the past, we had a very robust education department, kind of dwindled off, and now it's starting to rebuild again. And so we can offer those services as people come to work with us. So.
And so they can feel they're going to get support.
Absolutely.
They can feel they're going to get experience. So they don't necessarily have to go to the bigger hospitals.
Right.
They can actually, and they can, I guess one of the benefits is you work with your community.
Yeah.
You work with it and you might know people. And
Yeah,
that
absolutely
you're going to
right.
feel more comfortable. They're going to feel more comfortable. So that seems like that would be a big benefit as well.
Our inpatient unit is what we call acuity adaptable, or a progressive care unit. And so you could be hospitalized for a condition that means you're only there for a day or so in an observation status. We're just watching you, trying to see what's going on with you, do some testing. Either we'll decide to keep you acutely, discharge you home, or transfer you to a larger institution that has more services and resources. We could end up keeping you in our own facility for a lot longer. We're used to caring for people who are quite ill, so somebody that may need kind of like this borderline ICU type, almost there but not quite there service, those nurses can take care of those patients there too. So what we offer is not a pigeonholed unit department, but you could end up caring for someone across the span of their illness. So it's a fun opportunity if you're a new nurse.
Well, it seems like that's like the key to job experience. If you want to either learn to specialize or figure out where you want to be, or if you want to move up a chain,
right.
then you can get that. You can get that experience right up the road at Springfield.
Yeah, it's right here.
What are some of the challenges you face now, both in nursing and in the hospital hospital type? I mean, I know everybody probably has an idea, but like boots on the ground challenges that you face.
I think it's hard to really emphasize that you can have strong quality care close to home that is resource limited. So we only can do so much in our small hospital. And so I think that's probably our biggest challenge, is to know when to have those providers and nurses who are really skilled in their care, and to know when to transfer a patient and when not, or to keep them a little longer. Not necessarily a problem to have, because it's great to have but it's a challenge for us. Transportation's an issue. It's really tough.
The transportation, getting people to other hospitals, is availability an issue as well?
Availability is an issue, because everybody's kind of struggling with the same thing. You know, we all have resource limitations. There's only so much money in the pot. Municipalities can only contribute so much to their own departments, and for every dollar there is, it's a $3 need. And so we've been collaborating, Springfield Hospital has been collaborating with the local EMS agencies, and that relationship has been phenomenal. We're thinking outside the box, coming up with new ideas, and to try to meet that need. So those are probably our biggest issues.
And you mentioned the ER department, and I know that you've done a lot of work on efficiencies in the ER, because everyone, if you say the word ER, they're like, oh, because you have this vision of having, exactly, bring entertainment, because you're going to be there. But I would like to hear, because I actually have heard it, so so I would like the community to hear some of the things, because it's pretty impressive what's been going on up there.
Yeah, well, we spent a couple of weeks, months maybe, kind of analyzing our wait times and seeing what was kind of getting in the way, what our barriers were. And what we decided to do was try a different staffing model. For those who are familiar with hospitals, it's the triage model. You got one point nurse to pull in the patient, evaluate them quickly, and then room them. That changing that staffing model has reduced our wait times upwards of 3 to 4 hours down to 1 to 2 for patients who are not complex. If they're more complex, they're going to be a little longer. So that in itself, that efficiency has been phenomenal. We upstaffed to different times of the day. So we tracked our volumes to see when we're going to see the most patients. And so we've allowed ancillary staff, so techs, people who are there to help support the nurses, and more nursing staff themselves. And so kind of just moved humans around to meet that need so that people weren't waiting. We utilize triage order sets. And so when you come in and you're ill and you present with certain chief complaints, nurses can initiate your care before the doctor can run in real quick and do a quick bedside evaluation and medical screening exam. That speeds up the process as well. If you can give something to that provider to work with, take a look at these labs, take a look at this, the x-rays come back, that kind of thing, it can expedite your care. So all of those things.
And then haven't you done some efficiencies with communicating if someone needs to end up in the hospital itself? Aren't there some efficiencies on that end as well?
Yes, yeah. So what we lovingly call the admissions pathway. The nurses that work with me are like, oh, every time I say it. But so we had to change how we communicated with each other. And so it almost seems silly to say, but small buildings, still communication problems. So how could we make it better? I will tell you, I thought it would be pagers, alphanumeric pagers, because I am older than I admit. And it turns out nobody knows how to use them.
Oh, that's funny.
Really?
The kids these days. I don't understand. It doesn't, how do I make it stop beeping? And I'm like, oh my gosh, we can't use pagers. But it worked really well with our IT department, and they helped us with iPhones. And so now we have a very secure, it's called Tiger Connect, secured app. So all your information is very, very private, and they communicate providers and nursing staff between units and orchestrate
Is it like
that flow.
text messages?
It's basically texting, yeah. And so I did have to take a little humble sit back and watch how they were talking to each other, and said, oh, they need iPhones. So once I got over myself, that actually has worked really, really well. And our provider groups are phenomenal. So them working together to help move patients through has been really important.
Because you have two new provider groups. You have a new provider group in the ER and then a different provider group in the hospital. Right. You want to speak just a teeny tiny bit to that? Because I don't know if we've talked about that in the past.
Oh, okay, yeah, sure. It happens in hospitals that sometimes contracted groups of physicians change places, and so we ended up very excited to bring on rural provider groups, which is our hospitalist group that works with us on our inpatient side. They are very familiar with critical access hospitals, rural resource limited places, so they understand us. And so it's been really phenomenal working with them. They've got a great model. It seems to be going really, really well. The provider group, my strong personal desire was to have a group of board certified ED physicians who knew their stuff. And so we actually ended up being introduced to a group that's based out of New York. I believe it's Long Island. My geography's not great.
I think you're right, yeah.
Yeah.
I don't remember the name, but I think you're right.
PEP, and it stands for Progressive Emergency Partners or Physicians. So that group comes to us highly qualified, full of energy, all know their stuff. So
how does that work? Do they rotate in and out, or
do
they stay?
Some of them are kind of local-ish. When I say local, I'm talking 2-hour commute times for a lot of our providers. So they'll come up, they'll work a 12-hour shift in the ED anyway. Sometimes they'll stay over at local hotels and do another shift or two, and then they head on home.
Oh, interesting.
So yeah.
And then I know with the inpatient, the rural health providers, the newest thing, and again, I don't think we've talked about this, but the newest thing is that now you have whoever's on call, like literally stays at the hospital in the building.
Yeah,
and that's part of their
fantastic
jam.
Yeah, it was definitely a selling point. We as nurses are highly qualified and very educated, but you got to have that provider.
You got to have that sign off.
So important. And so that was definitely a huge plus to have them in the building and to know they're right there. And in those nighttime hours, they have a suite that they stay in that's on our campus, and they're right there to come if they are needed for anything.
And they can't even, they can only leave within a certain mile radius.
Yes.
And they work work for kind of a chunk of time.
5 days-ish. Some are wild animals, and they'll stay for like 7 or 9. But yeah, that's about.
And they stay at the hospital for that whole time. Wow.
Yeah.
That's
So if you pair that up sometimes with how a patient stay, then you're getting some good continuity.
Absolutely.
Or potentially some continuity, depending on when you come in. If you happen to come in at the beginning of the shift, you're going to see the same person for that time.
If you have a 3 or 4 day long acute stay, it's most likely that you're going to see just the one provider, maybe 2.
That's huge.
It's huge, very huge.
It's huge from the perspective of when you're in the hospital and you're just not at your best, and just to not have to be somebody brand new every time that they come in to do a check.
They know your story. They know the history. Yeah, it's been great. Yeah.
You keep mentioning the term, and I think it's good to reiterate so people understand. What is a critical access hospital? What does that mean?
Yeah, thank you. Critical access hospital is a hospital that is within a 20-25 mile radius of any other hospital. And so for us here in Vermont, we are critical access. Grace Cottage is critical access. Mount of Scutney is critical access. So small, less than 25 bed census capacity. And again, that rural location, the distance from another institution. And so, and that has to do with access. And so if you have a hospital on every block, then a client, a potential patient can make a choice. You don't really get that much of a choice.
We don't really get that as much here because we don't have a hospital. And even though it does sound like they're close, they're sort of close. But when you need care, you want it as close as possible. You don't want it that extra distance.
Yeah, agreed. Yeah, that's why our EMS relationships are so vital as well too, because that's a highly skilled group of people that are going to get you to the place you need to be. So.
Yeah.
I've been very vocal, so I've been kind of dominating. So I'm going to sit back.
That's fine. I'm good.
You're good. So tell us a little bit about, like, just in general challenges that you're facing. Especially, I guess I would I know you've done a lot of work to speed up things in the ER. Are there still challenges? Are you still seeing like surge, what they call surge?
We're handling it differently now, so it's not as impactful on the patient side. But our staff they work really hard. The emergency department is huge for a small hospital. It has a 19-bed, which includes some chairs in the hall, a 19-bed capacity, and that's a very big emergency department.
I didn't realize you guys had that many beds.
Oh my gosh. Many. It's so many. And, you look and you say, well, where could we downsize? Where could we reduce it? We can't. The volume is so high.
What is driving it? Like, what do you see? Are there certain things that are the most common? Has it changed in the length of time that you've been in nursing? These are strictly curiosity questions on my behalf.
I would say people like to think because we live in the ski area, it's trauma, which it is. Some certain times in the year, it really is a lot of traumas coming through and associated with ski injuries, and it's why I don't do it. So, so I always joke I was born here, so I don't ski. So.
Well, truth. Funny.
So with that said, we see a lot of exacerbation from comorbidities. So people who are struggling at home with things like congestive heart failure, or diabetes, or COPD, and then sometimes something will trigger them to become more sick and they'll come in. And so it ends up being a really complex case. It's maybe not necessarily just a straightforward, let's just get some fluid off you. It actually ends up being hospitalization.
Is that like directly connected to the kind of reduction in access and the availability of primary care?
Statistically, that's what we're seeing. Yes. We serve an area that's impoverished. By statistic, it's 17% of the population of Springfield is at that poverty line or below.
And down here, I think we're even higher.
Is it? Yeah. It's inevitable. It doesn't mean you shouldn't, regardless of where you are in your status, does not mean you shouldn't have access to the best care possible. It's just sometimes people wait too long because they try to put it off because that's a financial burden. Even if you do have the benefit of insurance, underinsurance is an issue. It definitely drives, I know for us financially, it drives our own charity care and our own bad debt ratio, but it is what it is in our area. We still have to serve our community.
We do, and that's at the end of the day, that's the thing. You're still serving the people regardless of all of those things.
Absolutely.
And so just so people are kind of aware, if you're talking to your legislators, if you're talking to people at the government level, to really make them aware of the challenges in this area, in rural Vermont, that I think get forgotten maybe sometimes in the Montpeliers and the Burlingtons and the St. Albans and all those places. So I think that's good. We're down to like a minute, believe it or not.
Oh, you're right. That was
really fast.
Is there any last thing you want to leave the audience with? If they have I don't know. What do you want to leave the audience with?
Springfield Hospital is a gem, and the people that work there are very dedicated to the community and very dedicated to the health of that community. And so they're there for you. We hope that you never have to use the hospital, of course, that's what we always say, but please come in. We're welcome and open and at a bit of a edge of a Renaissance era, so we're ready.
Well, thank you for coming on.
Thank you.
I hope you come back sometime.
Thank you. Yeah.
Update us again.
Yeah, I'd love to.
But that's it for this week. We'll see you next week on the feed.
That's easy.